Now, there is a difference between your pulmonary and extrapulmonary ARDS. So, pulmonary ARDS accounts to about 85% of causes and extrapulmonary accounts to about 35 to 40% of ARDS. So, there is a significant overlap. So, you can have a pulmonary ARDS that can develop a secondary extrapulmonary feature or an extrapulmonary developing a pulmonary feature. So, there can be an overlap between these two. So, that is why this percentage, if you see, is coming more than 100. So most common causes previously was trauma. Currently, pneumonia and aspiration is very, very common. So what is inhalation injury? Very increasing in the form of vaping. So e-cigarette or vaping associated lung injury. For this, what they are saying is the onset should be less than 90 days. Secondary infections to be ruled out. Rule out secondary cause of infection. And you have your bilateral chest infiltrates similar to your ARDS criteria that you're using in your Berlin definition. So similar to Berlin definition with timing less than 90 days. So this is what they may ask. Timing less than 90 days, rule out secondary causes. So you call it as EVALI. So they'll have predominantly GGOs that will be more. We'll see what are GGOs subsequently. So how are you going to treat them? You use lung productive ventilation plus steroids here. So that is what is your EVALI. So drowning associated lung injury, direct and indirect, both ways drowning can affect. Salt water says freshwater drowning. However, you can just have your lung injury, direct lung injury there. So pulmonary means you are going to directly affect your lung. Whereas in extrapulmonary, you are going to start off with the vasculature or alveopulmonary membrane and then go into the lung. Sepsis, pancreatitis, burns, major causes. Sepsis accounts to about 40% here. Okay. So what is the difference between pulmonary versus extrapulmonary ARDS? So is there really any difference? So we know that if you're going to start a disease in the level of your alveoli, this is going to be in pulmonary. Whereas if the disease process starts in the lung, your extrapulmonary. In the vessel, it is going to be extrapulmonary. So here you are going to have excess amount of cytokine in extrapulmonary. Whereas in pulmonary, you're going to have less amount of cytokine. One. Second thing is there is going to be significant damage to the lung, so there will be a very low compliance. So if the compliance is low, there is going to be high lung elastance. Whereas there is going to be high chest wall elastance in extrapulmonary ARDS. One. Second thing is recruitment maneuvers are not very effective in pulmonary ARDS. Why? I'll show it subsequently. Whereas their recruitment is recruitable lung. So how do you say recruitable lung? We will say subsequently as well. So recruitable is you increase the PEEP, is the oxygenation improving or not? So that is what you are seeing. And mortality, although both are equal, the amount of organ failures are lesser in pulmonary ARDS, and whereas the secondary infections are more. So high risk of secondary infections and organ failure is lesser. So you are going to have predominantly only lung, other organs are less involved. Whereas in extrapulmonary ARDS, you are going to get increased amount of organ failures. But risk of secondary infections is relatively lesser compared to here. Now, so if I'm going to take your CT that I'm going to see, you're going to see three different zones. One is called as a upper zone, mid zone, lower zone. Upper zone is your functional zone or called as a baby lung. So baby lung is a functional zone wherein there is a maximum amount of gas exchange. So don't think baby lung is an anatomical defect or anatomical proven zone. It is a functional zone. So it is a functional zone to explain your dynamics. And the marker of your baby lung is what you are calling as a driving pressure, which is a marker of plateau minus PEEP. You subtract your plateau pressure from your PEEP pressure. So you're going to get your driving pressures. So your marker is your baby lung. Then you're going to get this area wherein there is a complete collapse. So this is your complete collapse. It is a completely fluid filled zone. This is your completely fluid filled zone. This is your complete collapse area. And there is this area between wherein there is partial collapse. So atelectatic alveoli. Atelectatic alveoli, you are seeing this area wherein you are seeing underlying lung, but it is not very clear. So you are seeing something hazy here, but you are able to see this underlying lung parenchyma. This is what is called as a ground glass opacity, wherein you are going to see underlying lung in the background and it is hazy. It is not completely white nor it is completely black. So that is what is your GGO. So to understand what it is GGO. So simple way to remember GGO. So how you can remember what is GGO? GGO is anything that is going to fill the alveoli. So causes for GGO. Because many times you will get a CT report saying multiple GGO consolidation, etc. How do you understand what is a GGO? So it can be blood. So that is what you're going to call as DH. If it is going to be pus, you're going to call it as pneumonia or ARDS. If it is going to be just some normal fluid, you're going to call it as pulmonary edema. Then you can have your cells. So especially if you're going to get cancer cell, you call it as a lymphangitis. And then you're going to get, rarely you can get your drug-induced effects, like your chemotherapy-induced effects or immune checkpoint-related effects. So that is your pneumonitis or pneumotoxicity from your drugs. Rarely you can have, very, very rarely you can have your abnormal protein that can infiltrate. So what are the proteins that can infiltrate? Classically is your pulmonary alveolar proteinosis. Classical definition for this, DGOs. So you can have abnormal protein that can infiltrate the alveoli. So these are the, or so rarely you can have a rare, extremely rare cause like your pulmonary amyloid. So you can have this infiltrative disorder. I'll just put it as your infiltrative disorder. Okay. This infiltration can be malignancy, IgG4, it can be multiple things. We can discuss on infiltrative disorder as a separate section itself. Uh, so this is the differences between the ARDS and extrapulmonary ARDS. So you understood causes of GGO. So now this definition is very important. So what is the importance is baby lung. So this is your relatively normal alveoli. This is your completely filled alveoli and this is your partially filled alveoli. So importance of this is if I give some positive end expiratory pressure, so this is like your completely collapsed balloon. So it is like your completely collapsed balloon. So I need excessive efforts to blow it. Okay, even if I put more effort, what can happen is if I give more pressure, it can go and over distance these two areas. It can open up this area and over distance this area. Whereas it may have negligible because um, whatever flow happens across your path of least resistance. So these two areas will be the paths of least resistance compared to this. So this is what is going to happen. Okay. And whenever you're saying a diagnosis of ARDS, you always pause and ask, can there be an ARDS mimic? So two or three things that is very, very commonly missed that I have seen in practice. One is DH. So very, very carefully trend the HB. So it may be as simple as 12 to 10. And you may have an evidence of an increased LDH. So it can be because of your blood draw in the hospital also, but you should not miss out a DH. Okay, because you are immune versus non-immune DH. We have seen in our section as well, in pulmonary vascularity section, etc. Immune DH, there was a scoring that we saw. In hemoptysis section, we have seen DH. In immune DH, we have the four parameters that we consider. So if the score is more than 4 or more than 3, then you consider it as an immune DH. So fever, arthralgia, onset more than 11 days, etc. So if any of that is there, you have immune DH. So if it is an immune DH, it is more likely to be responsive to steroids. So that is why it is important to not miss out on this. I have seen so many times you can have acute presentation of your vasculitis, like your GPA or MPA that can present with just respiratory failure. And and many of the times it has been treated like your ARDS and not improving. So, and if you lose time on immune DH, the patient will not give you time. So that is why it is very important to pick it up early. So that is the importance of picking up these ARDS early. CHF we know. So how can you differentiate CSF versus your normal chest X-ray also will have bilateral lung infiltrate. Whereas your pulmonary edema also will have. So what are the points that is favoring pulmonary edema will be presence of your bilateral pleural effusion. If you have bilateral pleural effusion, presence of cardiomegaly. These two things is going to favor your uh, pulmonary edema versus ARDS mode. Then you have acute ILDs. So this you will require CT plus minus BAL for to make this diagnosis. So that is why you should have a low threshold. Even when the FiO2 is, let us say, 40-50%, you should take a risk and go for a bar, especially in ARDS cases, to not miss out on these conditions. Acute HB, PAP, AEP is one thing that is very steroid responsive, and 25% of them will not have peripheral eosinophilia. So that is why it is important. In cryptogenic organizing pneumonia, you have some acute fibrinous OP. There is an unusual variant of organizing pneumonia which can present acutely. So all of this you can diagnose on bronchoalveolar lavage or BAL. So that is why you should have a low threshold to do this testing. Then you have capillary leak syndrome, I've told you, from immunotherapy or immune checkpoint inhibitors. And then cancer itself can present, especially your visceral crisis of small cell lung cancer or breast cancers, etc. So that can present like this. So this we have seen, ARDS mimics. So how are you going to see it on CT? So on CT, if you see here, you are seeing this area. So this is called a septal thickening. So if you see this area is very, very prominent. Normally you don't see this hexagon. Functional unit is here. In HRCT, we have seen an ILD section. This is your secondary pulmonary lobule. In secondary pulmonary lobule, we have seen this. So whenever you have your septal thickening and effusions, septal thickening, presence of B lines. All of this is going to say this is going to say CHF. And whenever you have this pattern, lot of GGO, pericardiac or peripheral sparing. You can say peripheral sparing that is there. So this is classical for your DH. DH, PGP, these two things you should not miss. Whenever you have this kind of a pattern, wherein you see pericardiac and peripheral is paired like this. So this is very, very important clue for a DH. So we have picked up so many DH like this. Okay, so that is importance of knowing this. And what is the pathophysiology? We'll have a brief discussion. We can discuss a lot in pathophysiology also, but it is not very clinically very high yield. Okay. So what is going to happen in ARDS? So what can happen? It can start from the alveolar end or it can start from the capillary end. So let us say you are going to have a normal glycocalyx that is going to be there. So you're going to have high amount of type 2 pneumocytes and type 1 pneumocyte. Both are going to be damaged. So once this is going to happen, there is going to be reduced surfactant production. So if there is reduced surfactant production, so this airway will collapse. Will have a tendency to collapse. One. So when it collapses, ventilation becomes zero and perfusion remains normal. So this is what is called as your shunt. This is in your extreme VQ mismatch. In early cases, what will happen is you may not have fully absence of surfactant. There can be reduction in ventilation and perfusion is remaining normal or mildly increased. So thereby you are going to get your increased amount of VQ mismatch, which is going to be less than 1. This may seep in to your membranes and increase your inflammation. So this is one way. Second way is the opposite, wherein you can have your infiltrate that can happening reverse. It goes from your lung into the alveoli. So what is going to happen is your blood vessel, your endothelium becomes leaky. So more it becomes leaky, your tight junctions are lost, and then lot amount of fluid is going to pass into your alveoli, and it is going to be a protein-rich fluid because your permeability is lost. So it is going to be protein-rich. So this is what is going to give rise to your membrane called as your hyaline membrane. Protein-rich fluid that is going to go into the lung. Then, so what is going to happen here? V by Q. So here your perfusion sometimes may reduce because of hypoxic pulmonary vasoconstriction and redistribution. So this is what you are going to get your worsening of your VQ mismatch again. But in these instances, V by Q will be more than 1. Rarely you can have perfusion which can be completely zero. Okay. So this is your instances wherein you can have your secondary pulmonary embolism, especially where we were seeing in COVID, you had your lot of microthrombi and increased development of pulmonary embolism. So in those instances, your perfusion becomes zero and ventilation becomes normal or very high. So this is your secondary PE that you can develop. So once this happens, what happens? So once this happens, only ventilation is happening without exchange. So these two is going to increase your dead space. If you're going to increase my dead space, what is going to happen? We know your alveolar ventilation or mechanical ventilation or minute ventilation is going to depend on tidal volume minus dead space into your respiratory rate. So once your dead space increases, your effective tidal volume is going to decrease, thereby minute ventilation is going to decrease. Thereby, this gives us to the concept called as hypercapnia. So you are going to get your hypercapnia even in severe ARDS. You can get your hypercapnia. So we saw that CO2 has an ability of passing through membranes very easily because of lipophilic nature. So that is why you have to have a significant damage to the dead space to have your hypercapnia. And this gives rise to hypoxemia. So you can have both hypoxemia and hypercapnia. We have seen how.